Okay, so you should have your new note packets. Take a second for these to get fired up. So your next unit's on bone. Bone's a little boring, okay, just like skin was. 201 is a little dry compared to 202, but picks up in the next unit with muscle contractions. Yeah? Oh, you lucked out, I do. There you go. Uh-huh. So don't hesitate during any of this to ask questions, all right, so that you get it clarified. Sometimes getting it clarified sooner rather than later helps. That one's slow to come on. Okay, so we're going to look at bones. We're going to look how long bones are formed. We're going to look at joints, how they classify joints, that type of thing. For the first time here this semester, lecture and lab kind of dovetail together, even though lab doesn't really help for this actual part of things. So joint classification. Does anybody know what the study of joints is called? I wouldn't have either. What's the study of anything called? What's the ending they put on there? Ology. So it's some ology, okay? So you should have just said ology. I thought, oh yeah, there you go. So it's arthrology. Think arthritis, breakdown of joints. Okay? So they look at the anatomy of the joints, the function of the joints, that type of thing. And there's several different ways we can classify joints. And sometimes kind of confuses students when you switch classifications. Think of it as it's the same joint. We can just label it different ways based on the criteria. Just like you guys as a student, depending on what the criteria is, you would be in one group versus the other. It doesn't change who you are. If the criteria was gender, you'd be in this group, male or female. Ethnicity, that would change things. Tall, short, dark hair, light hair, brown eyes, blue eyes, that type of thing. As long as whatever the criteria is would change what group that you went with and who you would be in that group with. The same thing with joints. It's still the same joints. There's just different ways that they look at them. And one of the ways they do it is by function, which basically with a joint is talking about the freedom of movement. So the first type we have is called a diarthrosis. And this is a freely movable joint, meaning there's just lots of movement there. And when we think of joints, when we think of our elbow joint and our knee joint and our hip joint and our fingers and all, they're always diarthroses. Okay? So once we kind of get through this classification thing, we're going to be spending most of our time looking at diarthrosis. Okay? So if we have one that's freely movable, then we're going to have one that's less than that, and that's called an amphiarthrosis, and it's slightly movable. Okay? And we'll get into some examples of these down the road here. The third, if we have freely movable, a little bit movable, then we're probably going to have no movement at the joint, and that's called a synarthrosis. Little to no movement. And you guys that had lab on Tuesday saw some synarthroses. What would a synarthrosis be from lab? Anybody that had lab, want to throw something out there? Yeah, the sutures. All the sutures, those you're going to have lab today. You're going to learn these sutures, the skull bones, where they come together. There's no movement that takes place there. That's a synarthrosis. Okay? So if we classify them by function, these are our three groupings: diarthrosis, amphiarthrosis, and synarthrosis. We can do it by structure. Okay? This is classifying the joints about how the two bones come together. Okay? Because a joint or an arthrosis is any place that two bones come together. Okay? So we have what's called a fibrous joint. It takes just a little reach maybe for you to figure it out, but what, based on what you know, learned in this class, not what you learned outside this class and something else, what might be the thing that's connecting two fibrous bones together in a fibrous joint? What's the most common protein fiber? Collagen. So these bones are generally held together by collagen. Okay? The next one's easy. Cartilaginous joint. What do you think's in between the two bones there? Cartilage, there you go. All right. Can we think of one of those from lab? Pubic symphysis, maybe, would be a good one. All right. Where the two os coxae, the two pubic bone came together with a pad of fibrocartilage in between. Okay. Bony joints. These usually were some sort of other, whether they were cartilage or fibrous, generally fibrous, that became fused together. And so now at this point, it's bone fused to bone. So not super common that we even talk about them because they become just a bone of their own. But like the soft spot in the baby's head, okay, eventually that fuses. And so the different pieces that were there, some of them become bony joints. Not even really a joint at that point. And then here's the most common, the one we'll spend the most time with, and it's a synovial joint. Synovial joints are joints that allow for lots of movement, okay? So a synovial joint, if it allows for movement, it's probably going to be what type of joint by function? Diarthrosis. At the very least, an amphiarthrosis, but probably never a synarthrosis. If it's designed for movement, then it's not ever going to be one that there's with no movement, okay? All right. Doing all right with just those so far? Okay. This picture, there's nothing to really write down here. There's a couple concepts to grasp, okay? One we just kind of touched on. Synovial joints are oftentimes diarthroses, so you see this going across there. And sometimes there's a few synovial joints that would be considered amphiarthroses, okay? I don't even know exactly which they are. It's almost always a diarthrosis, but it can be, okay? Fibrous joints and cartilaginous joints. Think of that pubic symphysis. Is there a lot of movement there? No. At best, fibrous joints and cartilaginous joints hope for a little bit of movement. So at best, they could be an amphiarthrosis or a synarthrosis, and both of those are the same, okay? So we know if we have a diarthrosis that if we looked at it based on its structure, it's going to have to be what type of joint? Synovial, okay? You guys see that? Now, that's, in a way, now that you've seen the first test, some of the ways that questions get asked. We present the information. I gave you everything you needed to know to figure that out, but I didn't specifically say until just then by asking the question. But you had enough to connect the dots, okay? Because that's a lot of what you're going to be doing in your respective fields. Taking in information and thinking about it and making decisions, okay? It's not just a recipe, if this, then that, okay? It's if all these things, merging them together, figuring out what to do next, okay? So critical thinking is important for you guys. Which of the following is not a consideration when classifying a fibrous joint by its movement? So which of these isn't an option when doing a joint by its movement? This following is not consideration when classifying a fibrous joint. Okay, cool. So what's the answer? Okay. How many think number one? How many think number two? Number three? All right. You guys have a test hangover. It's one. A fibrous joint and cartilaginous joint at best could have how much movement? A little, right? Which would have made it an amphiarthrosis. Or it would have no movement at all, which would make it a synarthrosis. It could never be a freely movable joint, right? Which was the diarthrosis. There we go, thanks. All right, maybe we didn't have our coffee this morning. Do you see that now? Okay, cool. When you see it, a lot of these things are not that hard, but when you don't, I know what it's like when you're like, what? I don't get it. All right, so joints by structure. We're going to break them down a little bit further, or talk about them a little bit more anyway. So fibrous joints, You guys already told me what's going to fill that joint space, what's going to attach them together? Collagen. Good. I have collagen fibers in the space between the bones. That collagen goes to the matrix of one bone into the matrix of the other bone. And there's 3 types. So fibrous joints, one classification, and then we can get more specific. We have what's called a suture, a gomphosis, and a syndesmosis. Okay? And we'll give examples of those. They'll be coming up here in a second. Cartilaginous joints, once again, you guys already nailed this. We're going to have what between the bones? Cartilage, good. Bones bound to each other by cartilage. And there's 2 types there, synchondrosis and symphyses. Okay. What do you figure, once again, this is just a thinking question, I haven't told you, what do you think would change between a synchondrosis and a symphysis? What would be one of the factors that might have changed to make one and one the other? If cartilage is what's between there, what might have changed? There you go, the type of cartilage. Okay? So we'll see if that holds true. Okay? Now, it'd have been nice if they'd have just said cartilage joint with fibrocartilage in between and cartilage joint with hyaline cartilage in between, but they didn't do that. They gave them those names. Okay? Bony joints were bones fused by osseous tissue. Sometimes, or what they refer to them as a synostosis, and oftentimes these things fused or fill in with bony osseous tissue during growth and development. So early on in growth and development, actually, with like a baby. All right. So we've got some funky terms. We've got sutures, which you've heard of in lab, but gomphosis, syndesmosis, synchondrosis, symphyses. All right. So you can rest assured that you're going to want to have those squared away for the next quiz, because that's too much fun to play with those words and torture you. Okay. My life sucks, so I really get enjoyment out of torturing you. I'm just kidding, but you guys believe that. You guys kind of believe that, don't you? All right. Trying to just wake you guys up a little bit. All right, so the first fibrous joint is a suture, which, like I said, those of you that have had lab, you've seen a suture. Speaking of those that had lab, what would you name this joint? Sagittal suture, nice. What was this one? Coronal suture, very nice. All right. Now, those that have seen the sutures, is there any movement that takes place there? No. So they're immovable. We find them in the skull. There's what holds the skull bones together. And there's actually 3 types of sutures. So we don't worry about that in lab, we just name them. Okay, but there's 3 types. One is called a serrate suture, and that's what the picture's showing here, like a serrated knife. You guys, the knife that kind of has teeth on it that's jagged, good for cutting like bread. So this sagittal suture is a serrated suture, okay? And if you were looking at the real skulls in lab, you could see that. It's got these jagged edges back and forth, kind of like interlocking fingers. Appear as interlocking wavy lines. Okay, so that's one type of suture. The next type of suture is called the lap or the squamous suture. Okay, and these sutures have an overlapping beveled edge, meaning that one edge is cut at an angle, the other edge is at a matching angle, and they sit on each other that way. Okay, those that had lab, can you think of an example of where we'd find a squamous suture? Yeah. It was the squamous suture, right? That's what we called it. It was between the temporal bone and the parietal. So between the temporal and the parietal bone, that was the squamous suture. Okay? And then the last one is a plane or a butt suture. And now they don't have overlapping beveled edges. They have straight edges. So it looks like a butt crack when they come together. Okay? Which is truly how they named them. Really scientific. Okay? So straight, non-overlapping beveled edges. An example of that is the the maxilla, there's two maxilla. They come together like that in the roof of the mouth. So if you flip that skull over in lab and you look at the roof of the mouth, you'll see a straight line coming together. I think you can even see it down the front of the face as well. So those are the three types, okay, of sutures. Sutures are all fibrous joints. Sutures have no movement. All right? So if, once again, didn't tell you, but you have all the information. If we were taking this fibrous joint and classifying it based on movement, it would be a what? Not a synovial joint. Close to begin with an S, so I'm thinking, you were probably closer than what it seemed. Synarthrosis, right? Okay. All right, so here's some pictures to kind of go along with where you can find these. This coronal suture here is a serrated type of suture. This right here, this is the squamous suture. And they're comparing it to wood joints. I don't know much about woodworking. Maybe some of you guys do. So this serrated suture is like a dovetail joint, miter joint, overlapping beveled edges. And then there's the plain or the butt suture, like a butt joint. All right. Second type of fibrous joint is called a gomphosis. Okay. Gomphosis is found in one area. It's what anchors a tooth in its socket. Okay? It has what's called a periodontal ligament that they've tried to blow up right here in this picture that attaches. It comes out of the matrix of the tooth into the matrix of the bone, and it anchors it there and holds it in there. Okay? Looks like this. A bunch of these. Holding that tooth in there. Okay? And so because it's collagen fibers, it's a fibrous joint, and that's where we find it. All right. And so then we have one more type of fibrous joint, I'm pretty sure, and it's called a syndesmosis. So syndesmoses, syndesmosis, singular and plural. I don't care which way you would ever use. And this is found in two areas. It's found between the two bones of the forearm. What are the two bones in the forearm? Radius and ulna. Good. And the two small bones in the lower leg. Tibia and fibula. Good. Okay. And so these bones are bound by a ligament. And this ligament's known as the interosseous membrane. Osseous means bone, so between the bones, membrane. And this is a pretty good picture they've drawn of what it looks like. It's like a sheet that's between the two bones that helps hold it together. Okay? Holds this bone to that one. Okay? So you guys find it. It happens to be the most movable, wrong buttons. Most movable fibrous joint, and it's the radius and the ulna, or the tibia and the fibula. Now, once again, if this is the most movable of fibrous joints, what kind of joint would this be based on its movement? Not a diarthrosis, amphiarthrosis. Remember, fibrous joints, cartilaginous joints can never be diarthrosis. The best they could hope for in this world is to be an amphiarthrosis. Okay? Cartilaginous joints can only be amphiarthrosis or they'll be synarthrosis. One of the two. All right. Doing okay? I know it's tougher. You're writing stuff down. You don't have much time to think about it. So move on to the cartilaginous joints. There's two types. The first one is a synchondrosis. Okay? Anytime you see C-H-O-N-D-R-O, chondro, that means cartilage. All right? So that's telling you right there that this has something to do with cartilage. All right? So these are going to be bones anchored by cartilage. In the synchondrosis, these bones are anchored by hyaline cartilage. And the example they're showing are how the ribs attach to the sternum. Okay? So the ribs come around from the back, they wrap around, and then there's cartilage that joins them to your sternum, okay, making it a synchondrosis. Another example is an epiphyseal plate in children. The ribs to the sternum is a better example. Epiphyseal plate, you're getting into what are called growth plates. Growth plates are actually cartilage because bones grow from cartilage. So the cartilage is growing and the bone's changing, it's changing it from cartilage to bone as it grows in length. But technically, the two bones are joined by the cartilage, thereby making it a synchondrosis. Okay? And they bind the ends of the bone. I don't think we've gotten there yet. The end of the bone is called the epiphysis. The shaft is called the diaphysis. So this is a little foreshadowing of what's coming up down the road. Not exactly important just yet. So do we see how these ribs here, this left rib is attached to the sternum here, and this is cartilage. If you go in lab, you can see it on Skinny. Okay, you can walk over and look at that skeleton. It's a real skeleton, how everything's attached there. Okay. The second one for cartilaginous joints is called a symphysis. I bet you could give me an example of a symphysis. Pubic symphysis, good. Okay, so there, now, pubic symphysis, bones attached by cartilage. What type of cartilage was that? Wasn't hyaline, it was fibro, right? Because it was for, what was its function? Compression resistance, so shock absorption, okay? Good, so bones joined by fibrocartilage. So we were right, the two differences are what cartilage is between the bones, okay? This allows for only a slight amount of movement. The other one that they're showing is between the vertebrae. We haven't gotten to the vertebrae in lab yet, but in between each vertebrae, so here's one vertebrae, here's another vertebrae, and in between them there's a pad of fibrocartilage we know as the disc, the intervertebral disc. And it's a pad of fibrocartilage. Okay. Good. Synostosis, bony joints. Same thing we said a second ago. Two bones, once separated, become fused. This fusion, this what they'll call ossification, happens with age. As the person gets older, this will occur. Okay? And some examples. When a baby's born, we know the baby has a soft spot, right? Its mandibles in two pieces. Okay? Why would we have the baby born and the mandible maybe be in two pieces, the skull bones be in multiple pieces instead of the normal way they are? To help with childbirth, so that all those things can be compressed during childbirth, okay? Because that's a big baby's head going down a little canal. So you need to fit it through there, all right? So we have the left and right mandible that becomes fused. Left and right frontal bones become fused. And then back to that growth plate. In a child, there's cartilage there. Eventually, the cartilage is gone and it's all bone. So we essentially replaced the cartilage with bone. We fused it. So that's another example of what a synostosis would be. Once separated, then becomes fused together. You doing all right? Okay. Looks like we got a question coming up here. Which of the following is not a type of fibrous joint? And this is when all the words look the same now. How many think it's number 3? Did say the answer. All right, good. So, fibrous joints were sutures, gymphosis, syndesmosis. Symphysis was a cartilaginous one, right? It had fibrocartilage in between. So I'd probably get a question like that on your next quiz, I'm sure. All right, so moving out of that stuff, we're going to move into the synovial joints, okay? And because these are predominantly the joints we have, they're the ones that most movement takes place, they're the ones we're most concerned about, this is the ones we'll spend the most time on. these synovial joints, there's no cartilage between the bones. There's no collagen fiber between the bones. There's no bone between the bones. There's actually a joint space. They call it the joint cavity. Okay? So in this picture here, they're showing us, I think, a finger. We got the proximal phalanx and the middle phalanx, so the fingers, and we have a space between them. That's our joint cavity. Synovial joints always have a joint cavity. Okay? They also are lined, it's probably not going to come up on this slide just yet, but this lining right here in purple, this is called the synovial membrane. Okay, it's the inner lining here. And it secretes what's called synovial fluid. Synovial fluid lubricates that joint so that it can move even easier. Okay? Synovial joints are freely movable. Almost always a diarthrosis. Fibrous joint. Fibrocartilage is still cartilage. It's not collagen fibers. It's not collagen fibers. Okay, does that help? So you're just getting hung up on the word a little too much. Okay. Another thing you can see here before we go on, because it'll get talked about. So this portion right here, the inner lining of this is called the synovial membrane. Okay? Outside of that, so think of it like a sheet of paper. The inside portion, where the joint cavity is called synovial membrane. The other side of it's called the fibrous capsule. Okay? So you've probably heard of capsule in the joint. Sometimes people have a shortened or tightened capsule in their shoulder. That's part of the problem. Okay? So it's a thin sheet. They name it for two sides. A synovial membrane secreting synovial fluid into the joint. The other is just called the fibrous capsule. Okay? Which is what's coming up next. Fibrous capsule is lined or has a synovial membrane on its inside. And what it is continuous with the periosteum. So what you have, the setup with these bones, I wish I had a couple items here. If this fist is a bone and this fist is a bone, generally everything in our body has some sort of connective tissue wrapped around it. A lot of times dense, irregular, okay, which we're not worried about that, but it has connective tissue. And it wraps around the outside of the bone, okay, and it wraps around this portion of the bone. Well, it's almost like we took the two bones together, put them in close proximity, and then if we said that this connective tissue was like saran wrap, and then we wrap saran wrap around them both. Well, there would be saran wrap around this little space here, okay? Peri means of the, osteum means bone, so it's a connective tissue around the bone. If there's no bone there, we can't call it the periosteum, so they call it the fibrous capsule, okay? It's the same stuff, just in a different area. Does that make sense? And happens to be lined by what? Synovial membrane. Okay? Is that, we registering that? Well, it's kind of like, it's a, when you're driving here in Phoenix, what is it? Olive and Dunlap? You're driving along on Olive and next thing you know it's Dunlap. So I don't know if you changed towns there or cities, and that's why they did. I'm not exactly sure, but it's the same thing. It's the same road, they just changed the name. This is the same material, they just changed the name, but it also helps what? Hold the bones together. Okay? Now, it's not what really holds them together. What holds a bone to a bone? It begins with an L, and you know it. Ligaments. Okay? Ligaments will be outside of that, which will be even stronger, thicker connective tissue, primarily what type? Dense regular. Okay. It's like being in a fight, isn't it? Just like I'm punching you in the face repeatedly. Okay. Synovial fluid is the fluid. It's a serous type fluid produced from the synovial membrane that fills this joint. So it's a thin, watery secretion that's slippery. Okay? Which makes sense. If we're going to have these joints and they're going to have lots of movement in there, let's make them move as easy as possible. Okay, so viscous, slippery fluid. The fluid itself being in there does have a little, the fluid itself helps with a little compression. Not wonderfully, but it does. It's rich in albumin, which is protein, and hyaluronic acid, which makes it slippery. So this synovial fluid is like the KY jelly in the joint. Okay. Hyaline articular cartilage. She can't even look up. She'd put her head down. On the ends of the bones, what do we find on the ends of the bones? This is a little bit from last unit, just seeing if you remember. Not a big deal, but we had a type of connective tissue on ends of the long bones. Again, with an H. Hyaline cartilage, right? So this is hyaline cartilage. This is hyaline cartilage. We find it on the ends of the long bones where they come together to form the joints. If you've ever been eating chicken wings and you're kind of pulling the bones apart and you get that chewy, slippery piece in your mouth, you really can't chew it up, that's hyaline cartilage. So you put that on the ends with this slippery fluid and it makes like a frictionless environment for the joints to move, which is what we want. If we had friction, what would build up? Heat. Heat would break it down. We don't want that. Okay? So if this fluid dries up and then you get cartilage rubbing on cartilage and that starts to break down, what do we call that? What? Arthritis, osteoarthritis. Okay? So another little term that they change on us, this is hyaline cartilage. That's correct to say that. When they're talking about hyaline cartilage in the synovial joint, oftentimes they'll call it articular cartilage. Articular meant joint cartilage. So it's just basically telling you we found this in a joint versus hyaline cartilage that maybe we found holding the ribs to the sternum. Okay? And if you probably are realizing that A&P is a little bit like learning a second language as well. Okay? All these different weird terms and stuff that they use. So hyaline articular cartilage, sometimes I'll just put it both in there. I like to use them together just so that you get used to hearing them. And the reason I tell you is, once again, whatever book you got for reference, if you're in there reading it and I'm using just hyaline and maybe your book says articular, you're confused as hell. All right? Or vice versa. We don't want that. Okay? Doing all right so far?
Dr.
Yeah.
So our little picture
Uh-huh.
says articular capsule. Is that the same thing as the fibrous capsule?
Yep. Articular capsule is the same thing as the fibrous capsule. And see, that's, I'm glad he brought that up. I didn't catch that myself, but that's just how they have kind of different names for the same thing. Okay? And depending on what you're looking at or studying, if you're really confident about what you know, you see it and you make that connection. Oh, this must be that. Okay? If you're not real sure, then you're kind of like, WTF is going on here? He said fibrous capsule. This says articular capsule. I quit. I'm going to go have a drink. This sucks.
Okay, so I have a question about synovial fluid. So what happens if you have excess amount of synovial fluid? Say, for example, an empty, is that what causes it to swell up?
Yeah, if you damage something in a joint and then you get swelling in the joint, that's usually excess synovial fluid, which causes pressure and is a problem. Think of it. Think if you have a water balloon, okay, and it holds a certain amount of water. It's the size of maybe a baked potato. And you can bend it around, do whatever with it. It's not going to pop. You double that fluid or you put more fluid in there. Now the balloon's stretched a little more. You feel that pressure when you move it like it might burst. Now you're not going to burst your knee, but you're going to feel that pressure. Receptors are going to pick up on that. It's going to be painful. So that's why they ice it, to try to take that swelling out of there first. Okay? Doing all right? Huh? Yeah. A lot of times age, the cells there make it. The cells have gotten older. They're not making it as much. And when they and truly when they say the arthritis, usually they're talking about the cartilage breaking down. it's rubbing, and it's not meant to hold up under that. So the cartilage will wear away, and then you'll have bone rubbing on bone, which, as you imagine, would be painful. So a lot of times what your body does is says, F it. Bone rubbing on bone, this hurts. Let's fuse it so it can't move anymore. So that's when they'll start seeing osteophytes, little fragments of bone being grown into the joint. Their body's trying to stop the movement. That's what it thinks is the best thing to do. But they synthetically, I don't know, you follow sports or even for seniors, they're starting to try to come up with a synthetic fluid that they can inject in there to try to re-lubricate the knee. I think it has some benefits for some folks it hasn't. Those are some of the things they do. The cartilage, when it is damaged, cartilage doesn't, which you guys know, is cartilage vascular or avascular? Avascular. Anything that's avascular doesn't heal real well, okay? So when you damage the cartilage, it doesn't heal itself real well. So if you've torn cartilage in your knee, what do? They go in and they shave it and smooth it down, okay? Well, that's good. It's smooth now. It's going to glide better, but you just went from, and I'm making this up, 4 millimeters of cartilage down to 2 millimeters of cartilage. So in essence, what did they do? They sped up your breakdown in your knee, okay? But well, how did those types of surgeries and processes happen? Those were for football players. I'm paying John Doe $7 million a year. I want him back out on the field. That's the quickest, fastest way to get him back out there. It doesn't matter that at age 40, he's retired now of the league and he's walking around like this. I don't give a shit at that point. I'm not paying him then, okay? So that's how those things happen. And then what happens then is they get a knee replacement. They go in with a saw, they cut the femur, they cut the tibula fibula, and they put a device in there and they jam the bones in there that goes in one way and won't pull out the other. That's your knee replacement. Sew that thing back up, okay? Other procedures that they'll do, I don't know if you guys remember Amari Stoudemire, okay? So he had degeneration in his knee, and what they do is they go, what his procedure, I forget what it's called, they go in and they punch little holes in the bone, cause the bone to bleed into the joint, and then that bone, or that blood, excuse me, bleeds out here and then kind of almost scabs over, but not like a dry scab, like a wet scab, and that replaces the cartilage and hopefully keeps the bone from wearing on the bone. And sometimes that's effective and sometimes it isn't. But there's all these things that they're doing to try to treat osteoarthritis, and it's basically because the cartilage, once it's gone, it's not any good way of getting it back. Okay? So hopefully that was somewhat interesting as far as boring class is going today. All right? They do, I shouldn't say nothing, glucosamine sulfate does help regenerate some cartilage. It's slow. They have to have cartilage there to regenerate more. Works a little bit if you start it early on, but it's something that you take a lot of over a long period of time. Here's another picture of a joint, probably similar to what you have in your thing. We've got a bone and a bone. This would be the what? If I said, what's this area here? You'd call it the joint cavity, joint space. Okay. On the ends of the bones, we have cartilage, hyaline articular cartilage, hyaline articular cartilage. This orange here would be the synovial membrane producing the synovial fluid in here. The other side of the orange is the fibrous capsule, or here in this articular capsule. And then if you had ligaments, which you do, they haven't shown them, the ligaments would be outside of that. So they'd attach here and go around the outside of there and help hold that bone together. Okay? So it's fairly easy setup there on the synovial joint. Questions on that? Doing okay? All right, so synovial joint anatomy, some accessory structures. One of the accessory structures is going to be the meniscus. We've probably heard of the meniscus. Maybe don't know what the meniscus is, but we tend to find these in synovial joints that have a lot of movement. And if I told you the meniscus is a pad of fibrocartilage, it would probably mean that it's there for what function? Shock absorption. Okay? So these things have a function. If they're there, that's what they're there for. Okay? So a meniscus is a pad of fibrocartilage there that helps with shock absorption. Okay? So some of the places we find meniscus. The knee is the common one. Lots of force gets put through the knee. Running, jumping, running and stopping. All that puts a force, a compressive force into the knee joint. The jaw has a meniscus. The wrist has a meniscus. Your SC joints are your sternoclavicular joints. Okay? Sternum, clavicle. In here there's some fibrocartilage because there's lots of shock that goes in there when you fall down and you try to brace yourself with your arm. That force travels through there into that joint. Okay? So, it's fibrocartilage. It's there to absorb shock. The other thing, and we'll look at the knee because the knee is the most common, the meniscus does, is it's shaped in such a way to help guide the movement of the bone. Okay? And I'll put a picture up in a second. But the fibrocartilage, if you have this rounded edge of the bone, the fibrocartilage kind of fills in that gap. So if this is the end of the bone, you'll have fibrocartilage that's shaped kind of like this. Now, it'll be a little more under there, so the compressive forces will come down on it, but it's shaped that way that the way the bone moves, it helps guide it. Because if a bone, or excuse me, if a joint takes excessive force to it, there's a chance that that joint could then, what happens when a bone comes out of a joint? Call it a dislocation, okay? So any joint that there's lots of movement and lots of force would make it more likely to dislocate. The meniscus helps prevent that, okay? So it guides the bone movements, decreasing the chance that it's going to be dislocated. And it also helps to evenly distribute the force. Now, I'm not a good artist, and so my drawing isn't really good. I'd make it less high, and I'd put it a little more underneath here, so that when the force comes down, this whole end of the bone is sharing that compressive force. Okay? Which would you rather have? I'm about 240 pounds. Would you rather me step on your foot with just what I have on today, or one of you ladies that's about 120 pounds with your 4-inch pumps that's about a half an inch in diameter? Which is going to hurt more? Those little pumps are going to hurt like hell because all that weight, your 120 pounds of force was focused into an area about that big. Okay? Where my 240 pounds is going to be in an area the size of my heel. It's going to be more equally distributed. It's not going to feel as bad. Okay? That's homework. Go home and find some guinea pig and ask them. All right? It's just a reason to break out those shoes, ladies. They're in your closet. Get them out. All right? Other accessory structures. A tendon. What's a tendon do? Bone to muscle or muscle to bone. Either way you want to look at it, but that's exactly right. What type of connective tissue is it? Dense regular. See? Thank you. Thought I was going to start drinking heavy today. I'll wait till I get home. All right, so dense regular. All right? So really, the ligament and the tendon are the same tissue, right? But the name's different because one's bone to bone and one's muscle to bone. Okay? So attaches muscle to bone. It's dense, regular connective tissue. The ligament, you guys already told me, bone to bone. Once again, it's dense, regular connective tissue. Okay? We're going to have a picture coming up. I'll give you, it'll be a better probably thing for the meniscus here. So, here's this meniscus here and here. So it's the picture we looked at before. We got hyaline cartilage, hyaline cartilage. We happen to have one of our ligaments running through there, ACL, PCL. That's actually ACL. This is the joint space, okay? But here, because it's the knee, we have this pad of fibrocartilage, So when force goes this way, you see how that would help with that compressive force. it would distribute it all across the total surface area of that head of the femur, or condyle of the femur. Okay? You can also see it shaped in such a way that it helps guide the movement, lets it bend and flex like it normally does. Okay? And down here, they're showing you what it looks like with the bone gone, and that meniscus shaped that way. And what can happen is it can get torn, and then what will happen is it flips like a doorstop down into the joint. And so the knee will be, if that was this way and this way, the knee would come lock, and that would flip into the joint, and it would stop it, and their knee will lock out on them. Okay, and then they have to kind of work it around, and sometimes that'll flip out. But that's what they do. They go in there and they'll shave that down. Okay, so that it doesn't get in the way. But once again, those were all things that were there to help you, and now they're gone. So you're not in bad shape yet. You just have less wiggle room as you get older. Okay, but then you'll go back to that same surgeon for your knee replacement. Okay. Any questions on that? See how that works, the fibrocartilage there and there, meniscus? All right. Other accessory structures, we have tendon sheaths and bursa or bursae. A tendon sheath is connective tissue that you wrap around the tendon. Okay? It's connective tissue that's going to wrap around the tendon. So up here on this picture of the hand, we have these tendons coming from the muscles of the forearm down here to the fingers, and they're inserting on the phalanges. Okay? And then we've wrapped connective tissue around there to help kind of anchor it. Okay, those of you that lift weights and maybe heavy weights, sometimes you wrap your wrists to help give them a little extra support. It's a little bit of what they're doing here. That's so your wrist doesn't get bent back too much. This is so these tendons don't pull off of the bone. So they help anchor it to the bone. They help make it stronger. Now, because we want the tendons to slide within that sheath as frictionless as possible, the inside of that tendon sheath's lined by a synovial membrane. And what's the synovial membrane going to produce? Some synovial fluid to lubricate that area. So it's lined with the synovial membrane, and it's the same reason. Okay? Synovial fluid, frictionless, helps it move easily. So it makes it stronger and doesn't resist its movement. Okay? And so it wraps around the tendon, anchoring it to that bone. Okay? The other one is a bursa. A bursa is a sac-like extension of the joint capsule. So we take that articular capsule, joint capsule, and we just thicken it up in a certain area. And we usually put it between a tendon or a muscle and a bony thing in the, on the bone. So they're going to show you the shoulder there. The hip bone, we have this thing that sticks out to the side. What was that called? Not the iliac crest, it's up high. Greater trochanter, okay? And you have your IT band, and you have muscles running over the top of it, okay? It's a large roughened area. You guys have seen that on the femur. So it would make sense that if those muscles and tendons run over the top of it, that they could get chewed up by that, roughened up. So what we do is we put a pad of capsule, we thicken up the capsule around there and put it over the top of it to protect those. I don't know if any of you do any rappelling or anything like that, but you tie your rope off to a tree, you go over a cliff, and you put a mat down to protect your rope. You don't want your rope getting chewed up and frayed and breaking on you and you falling to your death. That's not fun. Or, you know, hurting yourself severely. Okay? That's what a bursa does. That bursa will get roughened up, chewed up, and it will become inflamed and hurt like hell, and we call that inflamed bursa we call bursitis. There we go. Thank you, somebody, for hitting the home run. Okay? So allow structures to slide easily over those rough surfaces. So in this area, we had the greater, lesser trochanter. We have that roughened edge. We're going to have a bursa there in your shoulder. Okay? So that anything running around and down has something kind of underneath it to protect it. A synovial joint can have all the following components except Can it have a fibrous capsule? Yeah. Will it have hyaline cartilage? Yeah. Will it have a joint cavity? Yes. Synovial fluid? Yeah, so it has them all. All right. All right, so joint movements requires more energy than I have today. All right, so joint movements. Any joint has different movements. It's not going to have all of these, but it could have some of them, okay? The first is flexion and extension. Flexion and extension we'll look at the elbow, okay? If I flex this joint, I'm decreasing the angle. Roughly the angle here is 180 degrees. If I do this, it's now about 90 degrees. It went from 180 to 90, it decreased. That's flexion. If the angle gets bigger, that's extension, okay? You can do that at the elbow, you can do that at the knee, I can do that at the hip actually, okay? So if I take my hip joint and I do this, what did I do? Did I flex it or extend it? Flexed it, okay? If I do this, I extended it, okay, good. Hyperextension is usually going past 180 degrees, and so think of that in your spine. If you look straight up, you're hyperextending. You can hyperextend your back by extending it too far. That's kind of where you'll find that movement taking place. Okay. Abduction, adduction. Okay. Abducting is taking something away from the midline. Adducting is bringing it back to the midline. Okay. So shoulder joint. If I do something like this, what did I do? Did I abduct or adduct? I abducted, abducted. If I did this, or even this, I brought it back to the center, back to the midline, I'm adducting, adducting, okay? Feel all right with those? Okay. Circumduction. Circumduction is kind of being able to go in almost a circle, okay? So once again, you have to have a ball and socket joint to do that. So you have a ball and socket joint with the femur, the head of the femur, in that cup-like depression of the coxa, which was called the acetabulum, good. And here in that little depression of the scapula known as the glenoid fossa cavity. Okay, so circumduction is being able to go almost in a circle. So if I was a girls softball player and I'm throwing underhand, pitching, that's circumduction. Baseball player throwing overhand, circumduction, just going different directions. Which is harder to hit? The guy throwing 98 from 60 feet away, or the girl throwing 75, 80 from 45 feet away? The girl. Girl gets there faster, okay? I don't know if you guys, sports science, once in a while, ESPN, they measure some of these things. So they took a major league pitcher, they threw him up there, and they put a plexiglass thing to measure how fast it got there and the speed of it. And so he threw it, and they did some measurements, and then they brought in, can't think of her name, pitched for University of Arizona, the Olympic team or whatever. First thing with the softball, just shattered the thing. And the time was so much faster. Like there's no time to react to that stuff. Okay, so that's the one thing that women are better at right there. Just one. That's a joke. I love women. I'm just teasing. There's mostly women in here. It wouldn't be fun to pick on the men. They're already outnumbered. All right. Lateral and medial rotation. So this is a rotation to the lateral or to the medial. They used to call it internal and external rotation. So what I'm going to do to show this is the movement's happening here. Some people get stuck on the elbow. It's not the elbow. Pretend I had a cast here. I can't move this. Movement takes place here. If I did this, did I medially rotate or laterally rotate? Medial, which would be the same as internal if your book used kind of an older term. If I went from here to here, that's external rotation or lateral rotation. Okay? See the difference? The elbow's not moving, so don't focus on that.
Could you go back to abduction and adduction?
Sure. So abduction. when some sick son of a bitch abducts a child, they take it away from their parent. All right? So we take it away from the midline. So I could do my hip if I don't fall down. If I did that, I just took it away. Abduction. Okay? If I bring it back, this movement here is adduction. Okay? Now we're awake. Yeah, people that hurt kids and women, you just shoot them. Forget prison. What do you think of that? Pretty hardcore. All right, supination, pronation. That happens with the radius and the ulna, the radius rolling over the top of the ulna. That's why it has that round radial head. It's actually to roll over the top. So going from here, palm up to palm down, it's taking place right here. This radius rolls over the top. That's pronation. Going from palm down to palm up, like maybe I was a waiter or waitress carrying a tray with soup on it, would be supination. Maybe that'll help you remember it. Palm up to palm down, pronation. Palm down to palm up, supination. Okay? In Fight Club, you don't ever order the what soup? The chowder, clam chowder. Okay? You guys not seen Fight Club? Who's not seen Fight Club? Oh my God. I just feel so frickin' old sometimes. All right. When class is over, watch Fight Club. It's good. All right. We'll give you movie reviews. You just don't have time now. You got to study, 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 study. Yeah, you got to know the rules of fight. Exactly. That might be the bonus question. We might have Fight Club. All right, so elevation and depression. Scapulas. You can elevate and depress the scapulas, okay? So whether I'm facing you or not doesn't matter. If I go from here to here, what did I do to my scapula? I elevated it. If I go from here to here, I depressed it, okay? Which is different than going forward and backwards, okay? Up and down, elevation and depression. Elevating, raising it up, pulling it down is depression. The other, forward and backward, is called protraction and retraction. So if I take the scapula and I roll them forward, that's protraction. If I pull them back, I'm retracting them. Okay? Opposition. Opposition refers to the thumb, and it's the ability of your thumb to touch any of your other fingers. So being able to do this, okay, that's opposition. Going the other direction, pulling it apart, is called reposition. Reposition isn't on there, okay? But opposition, we have an opposable thumb. It's why we're different than monkeys, okay? They can't do this. All right, inversion and eversion. Oh my God. All right. If I fall down, call for help before you guys leave class. Inversion. If I take my foot, the sole of my foot, and I roll it in. Okay, so going from here to there. I'll rip that down when I go too. Here to there, inversion. Okay? Here to there, eversion. So normally, any of you that ever sprained your ankle, what kind of sprain was it? Inversion. Inversion. Usually get it rolled in. Your toe and the sole of your foot gets inward. You roll over the outside of it.